See, now we are going to move to a key agent talk. If I don't know who is coming. Here. Sorry, one of the speakers is here. You may be Ana Vila?
Yes.
Okay, nice to meet you. So, yeah, thank you.
Good afternoon to everybody. It's my pleasure to be here in this Congress of Immunology, and I thank you for attending this talk. The talk will focus on the monitoring of the immunological response in the patient receiving a solid organ transplant, and which is the utility of the QuantiFERON on this setting. As you all know, the cytomegalovirus is the most common viral opportunistic infection in solid organ transplant recipients, and causes a lot of burden, clinical burden, but also economical burden related to the treatment and the admission to the hospital. In addition to the direct effects of the CMV infection, we have also indirect effects like the higher rates of superinfection, but also effects on the graft that mean sometimes graft loss or graft rejection, but also long-term effects like cardiovascular disease. This is a study published in 2020 from a Swiss cohort of more than 2,500 solid organ transplants that show us the high amount of infections. I have no, well, it's okay. Can you see the, yeah. Shows on blue the bacterial infections and in red the viral infections that account for almost 30% of the infections on the 7 first weeks post-transplant. And the CMV is one of the most prevalent. And how do we manage the risk of CMV in the solid organ transplant? The risk is stratified according to the serostatus of the donor and the recipient. And, as you can see in this slide, the donor positive that goes, that has an organ that goes to a recipient that it's negative, so it's not respondent to the CMV, meaning that has no immunity directed to the CMV virus, are on the highest risk. The recipients that are positive, that means that sometimes in the past have had contact with the virus and have built an immune response direct against the CMV virus, are on intermediate risk. And those who receive an organ that is negative, and they both are negative, the recipient is also negative, are on the lowest risk. So if we put this on a table, and on the left side of the slide you have the healthy recipient or the healthiest individual, you can see that when someone is negative and gets in contact with a patient that is, an individual that is viremic, you can have an infection. But in healthy individuals with which are immunocompetent, the infection will be mild. Many times it will be asymptomatic. But if we move to the next table, the one on the right side, that is the setting of the immunocompromised patient, you can see that if the recipient, the recipient of the organ is negative and receives an organ from a positive donor, the infection will be severe. If the patient is positive, that means that has some kind of competence against the CMV, perhaps could have a reactivation of its own virus that is in latency, or perhaps can have a reinfection. Other factors that affect the risk of CMV reactivation or disease in this solid organ transplant are the type of organ that we transplant, the viral load that it's on the graft, and the degree of immunosuppression that we give to the patient. As you can see here in this Swiss cohort, the grafts that are more prone to develop CMV infection are the lung, the heart, and the intestine that here is represented by the pancreas. The blue line, that is the kidney, is quite well protected. Other things that affect the incidence of CMV infection in solid organ transplant are the drugs, the immunosuppressive treatment that we give to the patients. And in this excellent work of Kamensky, you can see that it's a comparison between those patients that are have an induction therapy based on anti-CD25 monoclonal antibodies versus those who are inducted with ATG, that is a depleting antibody, and a depleting agent. And as you can see, I'm not, because, here. This line represents the basiliximab group, and this one represents the ATG. And you can see that is a significant difference between both of them, and with a highest incidence in the ATG group. But also we can do some things that are protective. For example, using mTOR inhibitors in the maintenance strategy of immunosuppression. And as you can see here, the mTOR group is the one who has the lowest incidence of CMV. Other factors that affect the development of infection after transplant are the availability of a specific treatment, the strategies that we do to protect the patient, universal prophylaxis or preemptive strategy, and time. What's universal prophylaxis? We give a patient ganciclovir or valganciclovir to all the patients at risk for 3 to 6 months, depending on the scheme you use. And the preemptive strategy means monitoring the viral anemia in blood or plasma, and just treat when the patient gets viremic. And the hybrid strategy means doing first prophylaxis and later the preemptive treatment. Both have cons and pros, but I will say that prophylaxis is more easy to use. You give prophylaxis to the patient and just relax. The patient is protected. While if you have a strategy based on preemptive, you need to monitor really closely the patient and detect early the viral replication, because if not, you will have the disease. And toxic and drug adverse effects of the prophylaxis need to be taken in account. So if we go to back to the table that I showed you before, if we are on the setting of the recipient that is in the high risk, infection could be severe, we can do a strategy based on prophylaxis. This patient, we need to protect it and be sure that would not develop an infection. While in the recipient that it's positive, we can do a strategy that can be prophylaxis or preemptive, or perhaps the combination of both. And why I said time before? Because time is very important to allow the reconstitution of the immunological system after the transplant induction treatment. And that's very important, and you can see here in this graph from Kamensky that in the very beginning after transplant, you can see here most of the cases of CMV in the basiliximab group happen in the very first days, on the first month after transplant. But in the ATG group, you have much more cases for a much longer period of time, and goes up to the day 200. And that's because the patients that receive a depleting agent need much more time to reconstitute its own immunity. But what say the guidelines? The guidelines, the third international consensus that promote guidelines to the prevention and treatment of the CMV were published in 2018, and they focused on many aspects, but one of them was the immunologic monitoring of the CMV in SOT. I need my glasses, I'm sorry. But they talk about these tests, ICS, QuantiFERON, ELISpot, and they say that all of them help us to predict viremia and predict disease. So they are all of them useful to being used in the transplant setting. But how we use them? And this is very important. This is the most important part of the talk, because in the transplant setting, post-transplant, if we use a strategy of prophylaxis, the CMI monitoring will help us to know when to stop it. That means if the CMI is positive, we can be sure that the patient is protected, so we can stop the prophylaxis. But if the CMI is negative, we cannot. We need to continue prophylaxis and the surveillance of the patient, because the patient is not protected at all. If we go to another setting, the post-transplant preemptive therapy, that means that we don't use any prophylaxis, but we are making a close monitoring of the patient. And in this monitoring, we combine the PCR, CMV monitoring, and the CMI. Then we can have some combinations. If we have the viral load is negative, and the CMI is positive, that means that no infection and the patient is protected. So no risk. We can be relaxed and keep monitoring the patient, but no problem with the CMV. If the viral load is negative, but the patient is negative on the CMI test, we need to be closing surveillance to the patient, because the patient is not protected, the patient is not infected either, but it's on high risk of getting infected. If the viral load is positive and the patient is positive, that's an intermediate situation, because the patient is on replication, on viral replication, but the immunity of the recipient is present. So perhaps the immunity of the patient could be able to control the disease. So we just need to keep calm, monitor the virus, and perhaps we will see that the PCR will stop increasing and just start decreasing the viral load. And if the viral load is positive and the patient is negative, we need to start treatment, because we have an infection with no immunity. We need to help the patient to control the disease with an antiviral drug. And another setting is when to stop the treatment. We have a patient that's been infected, and we have given him or her the treatment, the valganciclovir or the ganciclovir treatment, and the PCR is negative, because we won't stop the treatment if the patient is still positive. So the PCR is negative, and the CMI is positive. Okay, the patient is protected, the infection is under control, so we can stop treatment, and we can rely on the good outcome of the disease. But if the patient is negative and the CMI is negative too, then we need to start a secondary prophylaxis, because the patient is on high risk of release, because the recipient is not protected by its own immunity. This is our protocol in Hospital Germans Trias. We have worked on that based on these guidelines, and we have decided to give our patients on high risk valganciclovir for 3 months, and then monitor CMI. If it's positive, we stop prophylaxis, but if it's negative, we maintain prophylaxis until it gets positive. On the recipient that it's positive, so the patient has some kind of protection, but we give him or her immunosuppression, so we will unprotect him. If the induction is ATG based, we will give him 3 months of valganciclovir and then monitor the CMI and do the same as in the high-risk group. But if the patient receives anti-CD25 induction therapy, then we just do monitoring and just start valganciclovir for 1 month if the CMI is negative. And just some words for the future. That's a work of Haidar, and they suggest for the future to, when a vaccine will be available, to transform or convert the patients who are negative into positive. Because this is the most important thing that protects the individual to a disease, from a disease. And after the transplant, then we need to monitor the patient with the CMV PCR and the immunoassay. And if the patient gets viremic, then treat it. But if the patient doesn't develop a viremia, we can stop the surveillance, and that's all. So my take-home messages: immunologic monitoring will remain as a useful tool in the management of solid organ transplant. Other viral infections in solid organ transplant can be managed with the same scheme as we do in the CMV infection. The costs of the technique will be made up by the money saved on hospital stays and drug therapy and drug prophylaxis. And the immunologic monitoring allows the clinicians to have an insight of the degree of immunosuppression the patient has, and thus being able to adjust the therapy to the patient's need. Thank you very much. Questions now, or later both of us? No?
So, yeah, if anyone has any question, we can ask now. Yes.
Hi, thanks for your talk. When you say immune monitoring, you're referring to immune monitoring in blood or in the biopsy?
In blood of the recipient. I mean, a specific T cell monitoring, a specific T cell immunologic response against the CMV.
Okay, thanks.
No more questions? Okay, so thank you very much for your nice talk.